morning. I'll get us started. I think I know everybody, but I'm Monty Kane. I'm Stephen's wife, and welcome to the third part of our series we've done on this forum. The first week was about grief education. Last week, Mark Vanderlaan led a discussion about getting your affairs in order. And this is the final one in our series, so I welcome Dr. Peter Ruehlman. He is a retired hematologist, oncologist, 40 years of experience, and certainly has talked to a lot of families over those years and helped them make some difficult decisions. In his retirement, he serves on the board of Hospice of Cincinnati. I still call it that. We're now the navigators, which is actually an important distinction. So the trend in healthcare these days is to support somebody along the fullness of the trajectory of an illness. And so the navigators includes palliative and hospice care, palliative being symptom management that can be in any point in an illness. So he serves on our board, and part of his service is that he's on our speakers bureau. And because of his experience, he is well equipped to talk about how to talk to a doctor. We also have somebody from hospice here with us, Ted Brooks, who's here to answer any questions afterwards, and take it away.
Okay. Thank you very much, Mom. So this is going to be just probably a little bit different. Can you all hear me with the microphone and everything?
Yeah.
Okay. We're going to talk initially about mundane things, like when you go to the office, how do you talk to your doctor? And you're a pretty sophisticated audience, so I think you probably know, but there are things that come up that people don't think about. Some people never go to the doctor, and some people are there every day, it seems like. So I want to just bring out some points and really conduct this as more conversational. So just feel free to interrupt. That's what I want to do. It's not really a lecture. I've got a slide set, but that's the way it's going to go. I have to leave at 9:45. I'm the drummer in our local church, Mount Washington Presbyterian. And we start at 10:15, and we need a drummer there, so that'll be me. So I'm going to sneak out and let Ted take over at that point. So let's go to the next slide. So the first point is to take an active role in your health care. I've seen people that come in, this is maybe in the past, very passive. They come in and they just kind of listen and don't really have any goals. But you want to consider your lifestyle, your family history. Really nothing's off limits. Some things are maybe a little bit more sensitive than others. And prioritize your concerns. The doctor's busy, as you all know. He's looking for that doorknob, trying to figure out a way to get out. if you don't put it at the beginning, you're going to miss it. You'll get to the end, and all of a sudden he's out the door. He or she, I should say. And bring someone with you. Sometimes you miss things. Some things are emotional, and you try to process it, and you can't remember what they said, and having somebody write notes. Next slide. So share your symptoms, even if you feel fine, relatively speaking, especially new or bigger symptoms. Include medication side effects. I ran into a fellow, we live in Mount Adams, who has a bone cancer, and he was telling me about this chest pain that he had. He thought it was from the bone cancer, and I asked him, and he said, well, every time I walk down the block, I get this squeezing pain in my chest, and when I stop, it goes away. What does that sound like? Sounds like angina, right? But he was assuming that it was nothing, it was related to his cancer. And I said, you need to get your cardiologist ASAP. And Tuesday morning, he had 3 stents placed. So I'm renowned on the hill now for saving his life. He just had no idea that this was cardiac in nature. Next slide. So prepare your history, create a health history notebook. That may be a little OCD for some people. Include your family history, that's important for a lot of diseases. Bring this to your appointments. Prepare questions in writing. I can't tell you how many patients I've seen. I get to the end and I say, are there any questions? I've always made that, give them a chance to ask. And the husband looks at the wife, did we have questions? And she said, I think we did, but I can't remember them. So I can't answer the questions if they can't present them, right? Next slide. So lifestyle topics, obviously sexually active, smoking and drinking habits, important. We're finding out more and more drinking, even a small amount of alcohol can predispose to certain cancers. So really the best advice, and you won't want to hear this, is don't drink at all. If you can't do that, try to limit it to 1 a day or so. Try to do some exercise. Some people can do more than others, but find something that fits with your lifestyle and your time, etc. What about job stress? Are you moving? Moving is very stressful. We went through this about 4 years ago. We downsized. We're not thinking about having a baby. I don't think anybody in here is either, so that's not going to go on. About to get married. Sleep is very important and impacts every aspect of our health. A good sleep pattern. Next slide. So medication is prescribed by another doctor. Theoretically, that gets into Epic. You all know what Epic is. That's the electronic medical record system that all the hospitals use now. Most of the doctors, if they work for Christ or TriHealth or Mercy, they have access to this electronic medical record system, which has taken over the nation. It's called Epic. And theoretically, if I put a prescription in there and this doctor picks up the chart or goes into the chart, he should see that I just put that in there. So kind of try to keep up to date as hard as it is. Don't forget vitamins and over-the-counter supplements. Some of those do have interactions. People think they're natural, and so they must be safe. So anything over-the-counter. Next slide. So ask for advice. Dietary modifications. I'm really sad to report that most doctors don't have much training in nutrition. We can develop it along the way, but I can only remember 1 or 2 lectures about nutrition in medical school. So, but ask about it. They can refer you to a dietitian. Certainly if you're diabetic, you're going to need a good dietitian to work with you. He may refer you to certain websites. We're all on more and more computer avid these days, and books. Ask for extra time for a particular issue, and don't wait until you get there. Call ahead, talk to the receptionist, and just tell her, I'm having this particular thing, and I'm going to need extra time. Theoretically, they can budget that time and give you an extra whatever time you need. Let's see. I wanted to read that. Let me look at that. I diet religiously. I eat what I want and pray I don't gain weight. It's easy to tell the difference between good cholesterol and bad cholesterol. Bad cholesterol has an evil laugh. That's cute. Next. Note taking. We talked about that. Be prepared to take notes, either you or the person you bring with you, a family member, a friend who's committed. So ask a friend or family member to take notes. Record the visit. Always tell the doctor you're recording it. Generally that was not an issue, but sometimes I'd find out after the fact that was being recorded, and I didn't appreciate that. Write down questions in advance. Practice active listening. What is active listening? Anybody know?
Anybody? I'm thinking of the next question while they're talking.
Well, active listening, from the doctor's standpoint, is asking sort of leading questions. You say, my arm hurts. Tell me more about the pain in your arm and how long has it been going on, and kind of letting the person talk and listening. There's a little slide up there. God gave us 2 ears and 1 mouth, so we should listen at least twice as much as we talk, right? Everybody wants to talk and everybody's waiting for their little chance to get something in, but listen. When he talks, and the doctor hopefully has a good listening style when you're talking, the average, I read this somewhere, the average doctor can only tolerate 11 seconds of silence, and by then he's going to interrupt. So you got to be on your toes. Next slide. Communication outside the exam room. Do all of you use my chart? Any of you use my chart? You know what that is? You know what that is? Okay. Phone calls. More often than not, you get a voicemail, or they'll say, "We'll call you back," and then they don't call you back. That's my experience. Email, most doctors don't like email. It doesn't really integrate necessarily into the Epic system. Whereas if you use my chart, it's a permanent part of the record. And if another doctor wants to know about the conversation you had, you can see it all there. And just ask the doctor, what is your preference? I have a doctor who's, they call him a concierge doctor. You pay him a monthly fee. You probably know about that. And he will answer. He likes text messaging, and anytime, night and day. It's really been great. Fortunately, I don't have to see him that often. Next slide. So a little bit about end of life, and then I'll reintroduce Ted Brooks, who's from Hospice of Cincinnati. And this fits in, I think, with some of the other lectures that you've had. First of all, it's difficult to talk about death, isn't it? It's not going to happen to me. It's always somebody else. We had a speaker from Hospice a few years ago, and she very naively asked the group, what is the mortality rate for human beings? You know, and then she had a slide that went up 100%. So it's going to happen to all of us. They don't like to think about it. And in fact, doctors welcome such a conversation. If you're going to have a detailed conversation, that would be a point where you tell the receptionist, I need to talk about this. It's going to take some time. This is not a 5-minute discussion, not a one-time discussion. It's a series of conversations depending on the health status of the person. You know, if you're basically up and healthy, hopefully you all have living wills and regular wills and trusts and all that stuff. But as patients become older and get sick with 5 or 6 or 7 problems, it's important for the doctor to know your wishes if something bad should happen. Be proactive. Know how and when hospice can help. We'll talk about that. Best to have long before you need it. Yeah, so way in advance. Don't wait till you're on your deathbed. Reduce anxiety by having the talk. You may be anxious, but just talking about it can make it easier. And you want to make sure your family understands your wishes. You've probably all experienced this with different families. There's a local family who's tuned into the patient, and then there's the son from California who's not been part of anything. So he flies in, everything's set up, mom's going to be DNR, and he says, wait a minute, you know, I want to keep fighting for mom. You know, what's wrong with you? And so now you've got family members bashing each other. And sometimes we get involved from the ethics committee. I'm on the ethics committee at Mercy Anderson too. So it's a common problem, but make sure they understand what you want. Our kids we've talked to, my daughter's 30, my son's 28. We've been talking to them. You know, death has been part of my household since they were babies. You know, they don't get upset about it. Next slide.
Wow.
Is that it?
Nope. Went to sleep, sorry.
Okay, hospice. Have any of you had experience with hospice? Family members or a number of people? So there's Hospice of Cincinnati, which is who I'm on the speakers bureau for, which is a not-for-profit organization, and there's VITAS and a whole bunch of other ones that are competing in this tight marketplace to try to get patients. I think hospice is the only one that has a dedicated inpatient unit. There's one at Blue Ash, there's one at Anderson, there's one at Mercy West. So that can be very helpful at the end. Make sure your doctor has a copy of your advancce directives. You can talk about symptom management. So especially pain, most of us are worried about a death that's painful. Right? We've probably seen that with family members, and we don't want that. And so what is your definition of quality of life? And that varies from person to person. What's important to you if you have 6 months to live? What do you want to accomplish, if anything? How do you want to spend your time? And sometimes the patient hasn't really thought about it, but probe them, because all our days are limited, and we want to spend them wisely. Again, as I said earlier, it's not just a one-time discussion, it's a series of conversations. Is it the last one?
Nope, got 2 more.
One more? Okay, sorry. So resources, what is it? Advanced care planning, conversation starter kit. You can cover this, I think, Ted, can you? That's all this stuff. The next one? Questions. What questions do you have for me? Everything's perfectly clear. Yes, ma'am?
Well, with all the increase in medication out there, I've had several friends, and it could happen to me, where you take 2 medications and all those ingredients way down the bottom. There might be one ingredient in one that negates an ingredient in another medication. Who does one go to look at these medications?
To see about interactions, you mean? Is that what you're talking about?
Yeah, where
Well,
I don't have the knowledge.
the pharmacist should hopefully have your list of medications. And I've been called from time to time, there's an interaction here, and we would recommend you not take this medicine. Talk to your doctor about an alternative, because this one's going to interact. They have computers. I have a little tiny computer in my phone where I can do medication interactions. I don't necessarily trust it. You can look it up, but it's so confusing. But best to talk to a professional.
So go to your primary physician?
You could talk to him, and he's not going to know either. The pharmacist is going to be your best bet if you can get them pulled aside because they're all busy up here
Oh, man.
filling prescriptions. It's a nut house. Yes, sir.
Mental health for doctors. Drums for everybody.
Drums for everybody. Yeah, that's helped me.
I've often wondered about my general practitioner who was the little boy across the street.
Oh yeah.
And the mental health of somebody who's seeing patients day in and day out.
Yeah. Well, it takes my mind off. I mean, it's a completely different side of your brain when you play music, not drums or guitar or whatever. So I don't know if distraction is the word, but it helps you focus on something that's joyful and has a purpose, really, and especially in church. But, you know, drummers use all four limbs. I'm sure you've noticed that. Right, left, and both of your legs. So most people can't understand how drummers do that. I just taught myself, basically. I watched drummers and I figured it out. So. But music is so important. I'm sure everybody agrees with that, although we don't have the same style. Do you have a question, Lenny?
I do. You said theoretically the doctors have access to Epic and
Yeah.
are looking at everything. In my experience, that doesn't often happen. So I'm just wondering in practice, who really is looking at the fullness of a patient and everything that's going on?
Well, theoretically, your primary care doctor should have access if he belongs to a hospital system. It is mega expensive. If you're a solo practitioner or even a small group, it's not affordable. So a lot of them adapt their lesser systems. I don't know what they are. My group, the oncology group, we joined another group. They had their own proprietary system. All of a sudden, they kicked us out of Epic. We were using their system, which none of the doctors could see. And I screamed and yelled about it, but I didn't get anywhere. For oncologists, it was really good. You know, it had special things that made our jobs easier. But the referring doctors couldn't see our notes, and we have to series of clicks to make it sure it goes through to Dr. X. So theoretically, the PCP, but a lot of people don't have PCPs.
So basically, it's up to you to keep track of your own health and what else going on.
That's my approach. Yeah, I got notes in my phone from all kinds of stuff. Yeah. Yes, ma'am.
I understand that when one has a major test done, it's immediately posted to my chart.
Yeah.
And I have a friend who had this experience recently. She was so anxious, she went right onto my chart. It said that her cancer had spread through all her bones. It was blah, 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 blah.
Oh.
She was hysterical.
Yeah.
No, she finally finds out after she talks to the doctor's office, no, that was what they put in for insurance purposes to do the tests. But no, she was perfectly fine. Why is this that you have access to that my chart before you talk to your doctor?
I don't know. Most patients want access unless it's bad news, right? If it's bad news, you don't want to hear about it.
My friend, somebody told me that it's the law that it has to be posted to my chart as soon as it happens.
I don't know.
It's
But
awful.
I've been impressed. I just got back from the Mayo Clinic for some testing. Usually within a half an hour, the results will be there, even on complicated tests like CAT scans and stuff. So, I don't know, there's good points and bad points. Somebody over outside here? Yeah?
I've been in situations where relatives have had living wills,
Yeah.
and then a relative, as we go through treatment, will say, I don't want to do this. I think we got to do this. And somebody says, well, the living will says this, and they start amending it. Do you see people amending those wills like that?
It's really up to the patient, and I tell family members, this is not about you. This is about what your loved one wants, and your job is to honor their wishes. And sometimes you get into problems with dementia and things like that, so hopefully, like we said, this is all done. The patient is lucid and has control of that, but I think it's illegal you have to find an attorney who's willing to go in and amend it without talking to the person. That's not ethical. What do you think?
Well, it made me pretty uncomfortable.
ethical.
And especially if the patient is, like you say, a bit demented or is not capable of making decisions for some point of time after surgery.
Sure.
So I just wonder if you see that very often.
I haven't, but I'm not privy to that really. I ask every patient, do you have a living will? And more and more they say yes, but about 30%, more than that, of people don't even have a regular will because they're not going to die. This lady that was working for us for a while, in housekeeping, her husband died at 50, and he hadn't amended his will, and all of his money, he had pretty good assets, all went to his kids, and she got nothing. So she had to work for the rest of her life. She was really mad. Yeah, just hadn't been looked at.
And one last question. I worked for an insurance company, and for a short time, I was in charge of the long-term care division.
Yeah.
And we didn't keep that very long, but it was a whole different issue. But the thing that was interesting was that if you get long-term care, some of those policies dictate exactly what happens. The family doesn't get to choose.
Oh.
And they say this person's going to get assisted living, this person's going to get skilled nursing, and they would dictate it. And one of the good things that came out of it is that sometimes they say the policy's going to pay this. You say mom and dad want that, but here's what the policy's going to pay.
Yeah.
And we found that the children could never, ever get on the same track.
Really?
It's usually a long-term care person or some practitioner. Is there anyone outside of the insurance area that can kind of manage that
Kind of look at the policies with you mean?
Not the policies,
Oh.
manage the care, because the long-term care company end up driving the care based on the cost.
Isn't that dictated by what it says in the policy?
Exactly.
Yeah.
And they would say, we'll pay for this, you go where you want, we're gonna pay for this.
Yeah.
But then the family would be over there fighting.
Yeah,
I
exactly.
always promised mom she'd never go to a nursing home and all that kind of.
Well, a lot of them expire after a few years, like 3 or 4 years, then you're left on your own. And I should know that. You think, oh, I'm golden, but guess what? You live 4 years and you're off the planet. Yeah. Another question?
So, in terms of sort of general overview, and a sort of a simple statement, doctors want to work for a cure or for better outcome, and then if a patient says, no, I want to stop,
Yeah.
I want to stop treatment, how does that affect a doctor in terms of, well, we can't give up, we can't do this, we can't,
My approach was always, I'm here to serve the patient. If the patient tells me I'm not going to take treatment, I'm not going to make them take treatment. But let's talk about it, the pros and the cons. You know, some diseases, the chemo is horrible, but you end up being cured. You know, there's a number of them we can cure you, but some of them is palliative, you know what that word means? So, like pancreatic cancer, once it's spread, you can't cure it, but you can shrink it, make the person's pain better, make their quality of life. Then we're looking at quality of life issues in those situations. So,
do you see that more in experienced physicians as opposed to new physicians that are like, we got to fight, you know, that sort of thing?
I don't know. I'm not in their office with them. I would hope not. I would hope they develop some common sense. But you can't make a patient take treatment. If they say, I don't want it, I'm not. And how would you feel? I said, you're going to take this treatment, you're going to lose your hair, I don't care what you say. You know, so it's the dialogue that goes on. And you need to make sure they're informed of what they're doing. You know. Other questions? Yes, sir.
I wonder about oncologists
Yeah.
and the stress and strain of it.
Yeah,
You found an outlet through
Yeah.
hospice, I imagine.
yeah.
It must have been a wonderful thing for you to
Oh, yeah.
have this in your life.
Yeah, definitely.
It's a breath of fresh air for us physicians and the public to have hospice,
Yeah.
and it's just a wonderful thing.
I served on the board for 6 years for Leukemia and Lymphoma Society too. And that was just from a philanthropic standpoint. I
Yeah.
really love that organization, so I did a
Yeah.
lot with them.
Yeah. That's a good stress management technique, is
Yeah.
to serve like
Yeah.
that, like you've done.
Yeah, good. Thank you. Yeah. Other things? Yes, sir.
Is there anybody you can go to for a relative that's taking a bunch of drugs, go to and say, would you review these drugs and make sure these drugs are the most up to date? My brother's a pharmacokineticist,
Oh,
and he looked
ask
at
him.
And so he was looking at one of my dad's drugs. He says, you know, that's not the most up to date version.
No.
There's some more. And he looked at 3 of the drugs. And he said, you know, these are all good drugs, but he said these are not the most recent. And when he went to the pharmacy, they said, that's not our job to do that.
Right.
And so whose job would you get to make sure you're getting the most recent version of drugs?
I would talk to the doctor that prescribed them. You know, are they not up to date, or maybe there are other considerations, side effect profile, or sometimes cost. I don't know what the situation is with cost. Probably most of us here have some assistance with our pharmaceuticals. But again, the primary care doctor and maybe the pharmacist. Yes, ma'am?
That's what I was trying to
Yeah, okay.
make reference to. I'd rather go to a doctor just to make sure I'm not taking two things that have contradictory
If they interact, yeah.
I'd rather go to a doctor.
Yeah. Pharmacist has a computer, they can run that through.
Okay.
That's what I do. When I have that, yeah.
Somebody who's been involved with fire EMS for about 40 years, responding to a patient, taking him to a hospital, if that patient has a list of pharmacists that are already taking it, it's extremely helpful.
Oh, yeah.
So just have something, on the refrigerator wall.
Yeah.
It just makes a world of difference.
DNR order, right?
Yep.
Some people say put it in the freezer. I don't know if you would look there, but I heard that sometimes on the refrigerator. But in the crisis of the moment, people are panicked. They need to know where to look and to get it. And God help us if we resuscitate somebody who's got cancer and dementia. We don't want them resuscitated. So you want to pull it out and say, oh, this is the DNR. It's a signature here. It's all kosher. Yeah.
How do you deal with new drugs, brand new drugs?
It's tough in oncology. In the last 3 years, I think there have been more than 80 new drugs, and most of them have a very high price tag. And so you're constantly online looking at stuff and talking to people. I developed a list of experts in all the different cancers that I treated from going to meetings, and sometimes I would call them up and say, is this ready for prime time, or should I wait a while, stick with the tried and true?
Risk benefit.
Risk benefit, yeah, that's right, yeah.
It's tough with a brand new thing that hasn't
Oh,
been
it's
tried.
tough. It's tough to keep up, yeah. Yes, sir?
I think maybe 10 years ago, I heard a presentation by someone from Christ Hospital. I guess what palliative care became a residency requirement. It was,
I don't know that.
well, it was...
It is a certification. You can be certified in palliative care.
Well, people weren't being grandfathered in, we'll say, and that was, so they had started that program.
Yeah.
And then it seems to me we hear palliative care is now merging in with all the different hospice. So has palliative care not taken root, or is it truly independent? Or how
Well, it was not part of my internal medicine residency, nor was it part of my oncology fellowship, which is interesting. It's been a while since I finished up. We never talked about palliative care. Part of the problem is billing, and TriHealth has this program called PalliaCare. Have you heard of that?
Yeah.
I think it's mostly covered, maybe you can answer this, mostly covered by Medicare?
The challenges with palliative care was just taking a couple of letters out of it for Hospice of Cincinnati. But as far as reimbursement goes for palliative care, it's pretty minimal. So a lot of either nonprofit or for-profit companies won't put all their chips in that bucket. They'll utilize it, and they'll get some quality of life for folks in terms of managing their symptoms. And a lot of times those folks are going to qualify for hospice in a fair amount of time if we're already looking into it. And so, it's the business side that's out there, whether it's profit or nonprofit. So I think they see it, they try to have it as a resource for folks, but staffing-wise, to be able to help folks with their symptom management, a lot of folks have, a lot of things going on, a lot of multiple comorbidities, if you will. To be able to manage that and be able to go and see someone weekly, so palliative care is pretty much probably every 2 or 3 weeks, you're getting a nurse practitioner visit. So that's the extent of the program. It's really hard to make it a bigger program with the support that's behind it from the government.
But isn't it true, at least they were saying, once you're in hospice, there's certain drugs they got to pull you off, where if you're under palliative care, they don't have to pull you off those drugs.
Yeah,
Insurance
typically.
will reimburse as long as
Correct.
you're under that status legally. And I assume another question I've always had is, gerontologists never can make a living because of reimbursement. Is that still the game? Why would you go into those specialties, palliative care, gerontology, because no one will pay you yet? These are the people that will talk to you about the questions everyone has.
Yeah, when you're receiving palliative care, you're still going to be on whatever medications are going to continue to help.
And your doctor is still involved until you hit hospice. They can stay involved at that point, but more often they're left to the team to take care of, right?
Yeah. And with that palliative care team, you're still getting a good bit of attention, and they're going to look at what are your other medications that you are taking, and do you really need this? But it's a growing service now, and I think maybe the government will start to reimburse more for palliative care. They realize the importance of making sure someone's not in pain or that they have quality of life going on. So it's still growing. With us, with Hospice of Cincinnati, it's hard to keep up. We get tons of phone calls for palliative care, and sometimes we can't. It's not just us; it's anyone. It's tough to get out to see someone for 2 to 3 weeks.
At our last board meeting, we looked at dollars saved with palliative care, keeping them out of the hospital and minimizing their drugs and stuff. It was several $1 million.
Yeah.
So it's cost effective, but you got to convince the right people of that, because it just looks like an add-on.
Yeah, that's the goal, keeping folks out of the hospital as much as possible. No one wants to be there.
I'm going to sit down and let you pop up here now.
Okay. Go ahead. I'm Ted, by the way, again, and just real quick, I'll let you know I'm kind of a community liaison, so I help communication with families, hospitals, nursing homes. There, as you heard Dr. Ruehlman say, there's a lot of dynamics that go on, and so I'm kind of here to make sure communication happens, because in this area in healthcare, when communication's not happening, as you know, a lot of things go awry. So that's my role. I've done it for a number of years, and I've got some good experience with hospice. Go ahead. Yeah.
Just a question. I mean, very few people want to die in hospital, and yet I think they're not often aware that they have a right to ask to go home. And it depends on the hospital advocate, patient advocate. What's your experience of that? I mean, I've seen so many patients over the years who, they're going to die in the next week or two. They don't want to be in a hospital. They want to be in their familiar home surrounding. They want to be with their family. They don't want to have all the bleeping machines and everything else.
Yeah, that's a great thing, and we service a lot of folks at their home. Most people that are interviewed, they've been on hospice or family members have been involved with it. They do want to be at home, and we will honor that as much as possible. It depends on where they are in their trajectory. If they have, a disease state where their prognosis is 6 months or less, if it's really tough to transport them, or it doesn't make sense to transport them, then there are also, we have inpatient units. If we can get them to an inpatient unit and keep them somewhat stable, have a baseline for them to be able to travel safely, we'll get them there. But we absolutely promote, being home. It's just a more comfortable setting, and you've got people coming to you, and like you said, the hospital wants to get folks home too. They don't want people, how with COVID and everything, the demand for beds and staffing is so challenging. And ultimately, when you look at hospice, what I tell folks is it's extra hands, it's extra eyes, it's more people taking care of you that are already taking care of you. You've got obviously nurses and folks that are going to be there front line. But this is family members, a lot of times they're uncomfortable talking about it. They think of it as a death sentence, but you're getting more folks taking care of you. You're improving your quality of life, and it's nice. I mean, my mom, my dad, I want to know that someone's giving them as much attention as possible, because I can't do it all the time. Yeah, go ahead, Bonnie.
And to your point, Simon, I think back to Dr. Ruehlman, it does take being proactive as a family, because in the hospital, they often aren't going to bring up hospice or palliative care, at least in my experience, unless the family asks. And sometimes it takes pushing for that, because it is your right, exactly, and to have that conversation. And what a lot of people don't realize is that there's documented evidence that people live longer with hospice than without it. And so people assume they're going to sign up for hospice and they're giving up, but they sign up for hospice often and end up having longer life and certainly more quality of life.
Yeah. Thanks, Bonnie. And we're grateful to have Bonnie as well. She works with our grief area, and so it's a big team. It's social workers, it's STNAs that are helping turn people if they have wounds and things like that. So it's a complete effort, and the government recognizes the value in it. It's been around since the 1800s. You know, it came out of England, and it just continues to grow as a service. And right now, like I said, the staffing in nursing homes, those nursing homes will use hospice as much as they can because they realize the value if someone, you know, clinically qualifies for it. And then we always hear, we wish we would have started it sooner, you know. But yes.
Maybe I missed this, but what percent of your patients come on to hospice and go off it and come back on and off?
Yeah. Oh, so as far as I would say, you're saying one time or just a couple times?
Well, I don't know.
A couple times.
Whatever.
I would say probably 15%, 20%. You can really, once you get back to a quality of life, and I'm never going to say that someone thrives on hospice, but like I said, the quality of life and being able to just live comfortably and, you know, see family members, all that kind of thing, it does happen where they graduate from hospice, you know, and they come off the program.
Is that a,
Oh, okay.
is that a problem?
No, it's certainly, you know, obviously regulators are going to look, no matter who hospice you are, they're going to see, you know, is this person really getting back to a baseline? Are they eating again? Are they gaining weight? They have to look at all that in the equation. But, and we have to be very careful who goes onto the program, they have to qualify. Yeah.
So 15% would be a standard of...
I would say, yeah, where you've got some folks, you know, graduating from hospice and then coming back to it and then maybe going off again. It really depends on their trajectory and their disease state and their health.
Yeah.
I know you have an active pet therapy program. What's been your reaction with patients and pets?
They love that. I mean, I have one, I have the North Territory, so it's kind of like Butler County and all in that area. And we've got a pet therapist. She's a chaplain. She brings her dog around with her. She has like a baseball card with her and her dog on it, and they pass them out. Family members love it. Obviously, we can play music for folks. It's a program. You're trying to give someone. I always say when we come into this world, we celebrate. We get a lot of love. We get a lot of celebration. When we're moving on to the next round, we should also have a lot of love and celebration. So I think, you know, animals and music, you know, all that kind of stuff, it's helpful.
Very nice.
Yeah. Go ahead.
My mother had something very interesting. She lived in Austin, Texas, and my father was in a, not doing well.
Okay.
And my mother was called and said, there's one form that you have not signed. And he had the DNR and everything.
Yeah.
But if he were transported in an emergency situation to the hospital, the EMS, they're obligated to always give you care. And if you have a DNR, it's conflicting. And she had to go into the nursing home and sign this particular one paper that said, if you're in the emergency vehicle, they will not.
Yeah,
DNR.
so there's full code and then there's DNR, you know.
But if they don't know, they're obligated.
Yeah, and it's so hard because it has to be a doctor-signed document, and if it's not up to date, a lot of people will put their DNR or their full code status on their fridge, like he was saying earlier, so they can get it when they get to the house, have a copy of it out.
And she had no idea that this was a specific form.
Yeah, it's hard to have all the right paperwork in place. And that's a challenge too. You know, it's usually going to be advised, depending on where you are in your health status, to have that DNR, because if not, if you're 90-something years old and they're doing chest compressions on you, you know, to revive you and breaking bones and all that kind of stuff, that's when it gets real tough. You know? So it's good to have that in order. It's a difficult situation.
Out of our 4 parents, we'll say, all of whom are deceased, but 2 of them, and we weren't as directly involved because you get the different relatives and all this dynamics, but it's like, is hospice do the physicians give the hot potato to hospice? One was in, like a assisted living facility, one was in a hospital. And I think they survived 24 hours, another one 48 hours. Actually, with one, the first hospice visit was, I was physically in the room when this happened. Our first hospice visit was, the nurse actually pronounced death because everyone in the facility was waiting, because the hot potato is nobody wants, I think, the hot potato is they don't want the death on their facility.
Oh, yeah.
So the hospice became this blanket. And
Yeah,
so it's like, because, questions, we had in our mind, like, should they have been in hospice, one, for sure, long before this, or whatever. So is that the game? The physicians keep doing positioning,
they want
keep doing chemo and all kinds of crap like that.
Sure.
But they aren't there when the death occurs legal. Is that what the game is?
The physician's goal is always going to be to heal and to cure. That's an oath they take when they get that. But they're always going to do what's right for the patient, for the family. They're going to want them to be comfortable. And yeah, maybe sometimes hospice should happen sooner. It's easy for me to stand up here and say that.
One facility wouldn't bring them back. They've been living there for 14 years, unless it was under hospice just for that reason.
Okay. Yeah, it probably affects their mortality rates.
Yeah,
I mean,
right.
to be honest with you.
So they did like a 48-hour turnaround.
Yeah, but I would say it's still ultimately the goal is their quality of life. And a lot of times.
Well, hospice wasn't the problem. Hospice was great.
Yeah.
I didn't know the pressure you guys did.
I gotcha. Yeah, it's a tough industry.
Is there any movement in Ohio for physician-assisted death?
That I do not know. I wish I could answer that question. I don't know if anyone does. It's just not something that I follow. Good question, though.
There are about 11 states that do offer that, in terms of their legislature. Ohio's so conservative. I don't see them ever taking that.
Sure. Yeah.
Darn it, you're right.
Any other questions? This beautiful music in the background. Big day here.
Should we wrap it up? Anything else, Connie?
No, thank you all.